mainly talk about it's actually, okay, good, it was stuck. I will actually talk mainly about the patients who will receive a cardiotoxic treatment. But as you know, there are many other roles of echo in patients who have, cardiac and cancer issues. The cancer impacting the cardiovascular system, the patients who have cardiovascular disease and develop cancer, the patients who have received a cardiotoxic treatment and developed cardiovascular complications. But I think that most of the research has been done in patients who will receive a cardiotoxic treatment, and so that's what I will focus on. And I'd like to go back to the concept of how to explore systolic function, systolic cardiac function, in humans and in animals. And the idea of the LVEF that has been much maligned, but is still a huge prognostic factor, of course. So the LVEF was actually put forward in 1962 as a parameter of cardiac function that was independent of the size of mammals. It stayed rather constant from one species to the other, as opposed to, say, the cardiac output, for example. And then there was some very elegant work by Edmund Sonnenblick at Einstein that showed the relationship between the LVEF, which is here, and the percent change in sarcomere length in isolated papillary muscle, validating this concept. This is just to show you the recommendations of the American Society of Echocardiography that show you the different way of measuring LVEF. They don't recommend to do it in one plane. The biplane disc method of disc is sort of the mainstay of what we're doing. But obviously, if you can, and there's a big if, and I'm happy to discuss that after, if you can do 3D acquisitions, then there's no geometrical assumption, and that's what's recommended. So what's the role of echocardiography in detecting LV dysfunction? And I'd like to show you a statistic which I think is actually very interesting and that I think of quite often, which is from Tommy Wang, who published this from the Framingham study in 2003. And what he showed was that the prevalence of previously unknown asymptomatic LV dysfunction, so if you did an echo in the whole population, you would find about 6% of men and 0.8% of women who have asymptomatic LV dysfunction. So that's the yield of doing an echo in anyone. Now, people with cancer may have a higher yield of asymptomatic LV dysfunction, and older people, as you can see too. So what's the purpose of doing an echo pre and post anthracycline? Because this is, most of the research has been done in anthracycline. This is still actually under discussion. This is a paper that we did in 2015, and we looked at more than 2,000 patients who had had anthracycline and who had an echo prior to their anthracycline treatment. And what we showed, and I think that that's really one point of this paper, is that it's not only the patients who have EF lower than normal who have a high rate of, this was symptomatic heart failure and cardiac death, but also the patients who are borderline. I think that's a very important concept to have. They also have an increased rate of cardiac events. And so don't get hung up on one number is a bit the message I want to give. And this is a big breast cancer study from Raymond Romand. And what he's showing there is that, again, the patients who have EFs that are in the intermediate range, and that's pretty high, 64%, especially post-anthracycline, still have a probability of developing cardiac events higher than if they have very high EF. And I really like this graph by Connie Tsao. This again comes from the Framingham data. And what she shows here is that the LVEF, the prognostic value of the LVEF for heart failure and death is actually sort of a continuous curve. And that's how we should see it, rather than, again, getting hung up on one number, which people can't always agree on anyway. So what are the pitfalls of LVEF? And I want to really preface that by saying that LVEF is still a very strong marker, and that, you know, you shouldn't get discouraged of looking at LVEF. But this is a study by Daniela Cardinale, who has done a lot of studies on the role of troponin in particular in patients with anthracycline. And she followed more than 2,000 patients here with LVEFs every 3 months. And this is what she showed in terms of the evolution of the LVEF. And she showed also that, you know, so 9% of cardiotoxicity in her population, they were breast cancer patients. They were treated with quite high doses of anthracycline at that time. The important thing is that even when she monitored the LVEF every 3 months, and she would put patients on ACE inhibitor and beta blockers as soon as they had a decrease with an LVEF of less than 50%, there was a number of patients in whom the LVEF decrease was not totally reversible with treatment. And that is an issue of maybe sensitivity, and it led, you know, people to look for more sensitive indices of LV dysfunction. Another issue with the LVEF that's well known is the variability. Here's an older paper by Otterstadt that shows a standard deviation of 8.5%. And then a slightly more recent paper by Dinesh Tavandiranathan in Toronto in Tom Marwick's team. And the point of this particular paper, he was saying that you couldn't differentiate you couldn't detect a difference of less than 10% with the LVEF in the same patient. However, if you did a three-dimensional echo, then, you know, you could detect a much lower difference. But again, three-dimensional echo is not that easy to do. Other limitations of LVEF that are quite well known are it's dependent on load and on LV size. And I think that you're all familiar with the dependency of LVEF on load. I have to say in advance that strain is also dependent on load and on LV size, for those of you who wonder. But certainly a dependency, and you can see that at higher volumes, because of the Starling curve, you know, you can eject higher stroke volume for the same EF. And then conversely, you can see that a patient, you know, who has a small volume, you know, has an EF of 28% for a stroke volume of 25. However, if you have a much larger volume, your EF can be much lower. So the EF is not really reflective of the cardiac output and the contractile function, which is something that we did know. And this is a very nice, actually, paper by Marvin Constant that you could read if you were interested. So those two things, the variability and the lack of sensitivity, has led to the development of other parameters. And many of you in this audience are probably familiar with strain, which has, you know, generated a lot of press over the last 10 to 15 years. It's a measure of deformation of a solid object, and basically the one we use is Lagrangian strain, a deformation from the original length, L at T minus L at T0 on L at T0. And you can do that on segments or on the whole endocardial length as it's done at the moment. Just a few words on the advantages of strain, at least the theoretical advantages of strain compared with LVEF. And that I'd like to go back to the orientation of the myocardial fibers, as it helps explaining this. And you can see here on this drawing that the endocardial fibers are longitudinal, and then they wrap around at the mid-ventricular level, and then again become longitudinal at the epicardial level. And that results in a twisting and untwisting motion of the heart, which is quite complex. And that can be sort of artificially separated in three vectors: the longitudinal component, the radial component, and the circumferential component. Now, the fractional shortening, or LVEF, as you know, is a change in LV volume. The change in LV volume is very, very dependent on the radial function, very little dependence on the longitudinal function. So the LVEF really reflects the radial function, which in turn is due mostly to the circumferential and mid-myocardial fibers. So in theory, the fact that you can differentiate with the strain the longitudinal, circumferential, and radial components leads to a more comprehensive analysis of the myocardium, and it can better delineate layers that may be affected earlier than others, in particular the subendocardial layer. And it can decrease the influence of LV geometry, something we won't go into. So in theory, you can detect earlier changes than with LVEF. Another advantage is technical, although now we tend to measure strain as the endocardial contour, which takes this advantage away, I have to say. But if you are to measure the myocardial strain, for example, it's the average of multiple data points, and this, in theory, decreases variability. And then another advantage of the strain is that, again, in theory, you can do it spatially. So you can do different regions if in terms of wall motion abnormality, for example, to identify this earlier. And you can also look at the timing of event, which has been done in particular to look at dysynchrony. So this is a very quick slide. It's just to tell you that strain decreases after chemotherapy. This has been known for a long time. There was some early work from Javier Ganam and Roxandra Yorkut showing the early decreases just after one cycle of chemotherapy. The question was, whether it had prognostic value, and I couldn't resist to put some mice echocardiograms, as I have spent a lot of my career doing some mice echocardiograms. This is a dilated cardiomyopathy in a mouse next to an M&M, and thanks to very high frequency probes, we are able to image those hearts. They also beat at 500 to 700 per minute. So that's another difficult factor. But you can see here a very nice parasternal long axis view that has been slowed down, obviously. Igal Sebag, who came from McGill, did some work to validate tissue Doppler analysis and strain rate, so the rate of deformation in mice. And then more recently, there have been tools to look at the strain, so the integral of the strain rate, the deformation itself in mice. And this is being done quite routinely. So we got interested in that particular aspect, and Tom Nealon, who has developed a very nice career looking a lot at MRI and immune checkpoint inhibitor, I'll cite some of his work after, looked at, in mice, the effect of doxorubicin treatment acutely and chronically. And I think this was the most important finding, which was that strain rate predicted later survival in a doxorubicin chronic treatment in mice. And so we took this to humans and did some of the early studies, as Noel was mentioning, on the prognostic value of strain in chemotherapy-induced LV dysfunctions. And so many teams have done this and confirmed that measuring in particular global longitudinal strain early in the course of chemotherapy So we had done it at 3 months at the end of the anthracycline treatment in breast cancer, women with breast cancer. And we were able to predict the later decreases in LVEF. And so a series of teams have done that. And this is a summary by Oko Nomu in the team of Tom Marwick. And it shows you that if you have an abnormal strain, and we'll go a bit more into the details after, you have a very increased risk of developing subsequent LVEF decrease. So we and others, Negishi in the team of Tom Marwick, and that was our team, looked at a decrease from 0 to 3 months, and were able to say that a decrease in 10 to 12% was predictive of later decreases in LVEF. And teams are still looking at the prognostic role and now comparing it to MRI. This is a recent paper from the team of Dinesh Davendaranathan in Toronto. And interestingly, I thought in that particular paper, they certainly showed that the 2D echo parameters, adding the strain in particular, was actually at this point better than adding the MRI strain. So I would like to give some ideas of when it's valuable to use strain, because there is quite a bit of controversy with that. I'm going to go into a bit more. And I think that this is actually an important paper that's from Negare Mousavi, who is now at McGill. And what she showed here is that in patients with baseline LVEF between 50 and 59. So the reason why it may be an important population is that this is a population where you're not totally sure about the LVEF. Is it normal? Is it at the lower limits of normal? Is it, does it have any meaning? And so what she showed is that in those patients who were all treated with anthracyclines, the addition of strain, global longitudinal strain, to the LVEF actually brought some significant increase in the prediction of, and this was symptomatic heart failure or cardiac death. And this was at baseline, yeah? So if you are a bit uncertain about, stratifying the risk of your patients, this was a good way to stratify it. And what we had done is that we had looked at a threshold of strain of 16% or minus 16%, as you will. More recently, we became very interested in the population of acute leukemia. And that's still a topic that we're working on, actually, because it's a population at very high risk. I mean, certainly at Mass General, it was, and it's been reproduced at UPenn, where I work now. And I know that Nosheen Akhtar at Northwestern has a similar experience, and some others too. We found that those patients have quite a high rate, of symptomatic heart failure, 9%, which occurs quite early on, actually, within the first year. And so Yukang published in the JACC Cardio-Oncology a 21-point risk score. And you can see that the GLS is included there, and the LVEF, and then a series of other pre-existing cardiovascular disease and risk factor, anthracycline dose, and AML, importantly, leads to a high score. And you can see that in this high risk group, they have a rate that can go up to 40% of symptomatic heart failure in the first year. And I think that this is of great interest to me, because it sort of emphasizes again the connection between cancer itself and the heart. And that was a paper by Bruna Assunção, who is in Sao Paulo. And what she showed was that these were women without cancer, with breast cancer, or with acute leukemia. And these women were selected, they had absolutely no cardiovascular risk factor that we could identify. And what she showed in this paper was that even before chemotherapy, some of these women had really an abnormal strain. And so that was pointing out for us to a sort of a, intrinsic issue with the acute leukemia. We don't know if it's the cytokines that are inundating the patients or if there's something else, and that's certainly something that we're looking into. Another argument for that is that the pretreatment strain in the paper by Yu Kang also predicts the non-cardiac mortality in acute leukemia, as if it was a reflection maybe of the burden of disease of leukemia. So is 3D strain an improvement? I have to say that it's difficult enough to have consensus on the 2D strain, so this might be a bit premature. Bonnie Key at UPenn has done a lot of work. She's the director of the cardio-oncology at UPenn, and she's done a lot of work on echo and in breast cancer women in particular. And that was one of the work where she showed that the 3D variables changed differently in this cohort than the 2D variables. And that there was some prediction, although not that strong, of the 3D strain unfortunately, the endpoint was a change in 2D LVEF, which is a bit of an issue, obviously, but the rate of event is quite low, so difficult to get enough patients for that. So what are the obstacles with strain? And the strain measurements will only be as good as the tracking. I think that, as we all know, there is this famous curve of the initial enthusiasm and then the nadir of the enthusiasm go down. And certainly the enthusiasm for strain has been going down as we see some of its limitation, and hopefully it will stabilize after. But that's very true that, if the tracking is not good, you shouldn't report the strain. Another issue is the lack of standardization. And this is illustrated in this letter from the team of Tom Marwick in the JAC that showed actually the global longitudinal strain, not only by age group, but also they reported some of the different values of the different companies. And you can see here TomTech, which is a vendor independent strain measurement, GE and Philips, which are quite well used, and you can see that they all have different values. And here I've put a bar on the 16, which is actually something that we have, that's what we're doing in our lab. And it is more of a common sense, if you will, take on the strain. But it's also been validated by, it's been accepted, I should say, by many other teams. This is just another paper by Susan Cheng, and what she was reporting was that with the TomTech in men, healthy older men could have a strain as low as 15%, really. Okay, so I just want to spend a bit of time on SUCCOUR, which is a recently published study, which was a huge amount of work that Dinesh Tavandiranathan in Toronto was the first author on, and Tom Marwick was the last author on. And it was very, very awaited by the field because it was basically an attempt to prove that guiding patients with strain would lead to better results, and putting them on cardioprotective therapy would lead to better results at the follow-up than guiding patients with EF. And they did an extremely intensive work and published the results recently in the JAC. They did enroll the number of patients even more than they were going to enroll. It was a multi-center study, and they published their one-year result. So the first thing that they noted, which is not very surprising as strain is more sensitive than EF, was that there were many more patients who had a strain reduction. They took a 12% fall than patients who had an EF reduction. And in a nutshell, the results of their study was unfortunately negative. Although they had many more patients who had a decrease of strain, and so that they placed on cardioprotective therapy, there was no difference at 1 year at least in the EF between those two groups. So, you know, some of the explanations that they gave was that the EF by itself is an imperfect endpoint. We will see what the results will be at 2 years. So for the moment, there is no proof that guiding yourself with strain, you know, will change the endpoint, at least of 2D EF. Another point that some people made, and you know, this really emphasizes the importance of the close relationship between cardiologists and oncologists, is that in the GLS guided group, there were 5 interruptions of the I remember well, sorry, 9 interruptions of the treatment for cancer, and some of it was linked to the decrease of strain, which is not something that we would recommend at this point. So I'm going to move on to some of the newer therapies, and then we'll come back as a sort of conclusion to, you know, how to put everything together and how to use LVEF and strain in the population treated by cancer treatments. So the newer therapies that I'm going to talk about are the CAR T cells and the immune checkpoint inhibitors. The CAR T cells are the chimeric antigen receptor cells, and they're basically cells that are targeted, lymphocytes that are targeted to attack cancers that are linked to B cells. And so they've been used in acute lymphoblastic leukemia, and they've been used now in lymphomas, and they're extremely efficient in some resistant leukemia and lymphomas. However, they can be linked to cardiovascular complication. There is not much work about this. So our team, and Bénédicte Lefebvre comes from Montreal, and she actually spearheaded this particular study. This was a retrospective study at Penn. We had 145 patients. The CAR T cells were developed at Penn, so we had quite a large population. And as you can see, there was a number of patients who had major adverse cardiac event, including 15% of patients who developed symptomatic heart failure. This was actually very early on and very, very linked to the cytokine release syndrome. Echo was not done on all patients, but it is clear that there was certainly an effect on the ejection fraction. Whether, you know, doing strain before would be predictive is something that we're looking at now prospectively, but it's unknown as for now. There was another paper retrospectively too that was published from Tom Nealon's group, and that said that troponin might also have a prognostic role, so to be seen. Now, the immunotherapy, the checkpoint inhibitors have been really having an exponential growth in terms of indications. There was a very recent paper on triple negative breast cancer in the New England last week or 2 weeks ago. And so really, it seems like more and more of the cancer population may have some of those checkpoint inhibitors. So how do they work? So there are several systems by which the cancer actually makes its way in the body. And some of this system is the PD-1, PD-L1 system. The PD-1 is the programmed DEF1 protein. It's an inhibitory transmembrane protein that inhibits T cells, and it links itself to PD-L1, which is the ligand of PD-1, and that is presented by the tumor, and it inhibits the T cells. So it prevents them from attacking the tumor. Another of those systems is the CTLA4, which is also an inhibitory way to inhibit the T cells. So those immune checkpoint inhibitors are going to link to those receptors, if you will, and then they're going to prevent the tumor from inhibiting those T cells. Unfortunately, it's been shown that cardiomyocytes, in particular injured cardiomyocytes, such as in patients who have atherosclerosis and some little injury of their heart, express also this ligand. And so there are, unfortunately, some side effects of those immune checkpoint inhibitors, and the most well-known of it is the myocarditis in the cardiology world, of course. So there's been quite a lot of work, in progress done, and we don't really know the incidence of the myocarditis. The best we can say at this point is that the symptomatic one seems to be below 1%, but there may be a lot of asymptomatic myocarditis. One of the issue with these myocarditis, this is work from Mahmoud in Tom Nealon's team, is that the LVEF is very often normal. So there may be a role of strain. I mean, there may be a role of MRI too. There were two recent papers in the JACC from Tom Nealon's team that showed that maybe T1 in particular may be a good parameter to triage patients for subsequent MACE. But here is the echo part, which I'm going to present. And this was in 101 patients with immune checkpoint inhibitors myocarditis. It was a multi-center study. And look at the rate of MACE that they developed, 51%. So obviously a very severe, a rare condition, but very severe. And the role of strain in these patients may be somewhat encouraging. This is some strain that's been done at the time of the diagnosis of myocarditis, as patients are not followed serially with echoes or with biomarkers for that reason. And you can see that patients who had reduced EF and very low strain seem to have more MACE than patients who had sort of rather preserved strain, although it's not totally preserved at 13%. And then in preserved EF, that's where maybe the main role would be. But you can see that patients with lower strain, less than 16%, would have a survival MACE-free that was decreased. So still needs to be confirmed, but some encouraging results. So now what do we do with all that? And there is a lot of discussion. I'm going to leave you with a few simple things, but that have to be adapted on case by case. So this is some older guidelines from the ASE by Juan Carlos Plana and the whole group, yeah. And they weren't really helpful because as soon as the LVEF was lower than 53%, which was one of the points that the ASE recommended, actually 52 in men and 54 in women, which makes it even more complicated. Or if GLS was lower than the lower limits of normal, and then each company has its own lower limits of normal, and it depends on age, or if troponins were positive, then you would get a cardiology consultation, which is not totally helpful, I should say, but that's where we were in 2014. The American Society of Clinical Oncologists did a good job of differentiating, and I think that's a very important thing, to sort of in your head stratify your patients as who is at increased risk and who is not, and your behavior towards the patients may be different based on that. High-dose anthracycline, radiotherapy, multiple risk factors, older age or compromised function. And then they didn't say too much. Routine surveillance imaging may be offered, and frequency of surveillance should be determined by healthcare providers. So from the ACC Cardio-Oncology Council, Jennifer Liu and a few others, we published a sort of practical implementation of strain. And I think that one thing that's interesting is in those patients here with the EF that's, between 50 and 59, as, if the EF is lower, we'll probably give some cardioprotective medications. And if the EF is higher, there's really no need to worry. So what do you do with those patients? So a GLS of less than 16%, if the tracking is good, if you've maybe a cause for very slight, I wouldn't say concern, but at least, that you should be aware of. And it's a marker of increased risk. So consider contributing pathology, optimized cardiovascular factors with closer surveillance, and consider cardioprotective medications if you have an excuse to prescribe ACE inhibitors or beta blockers, just do it. A last thing I want to point out is that there is a big impact of COVID on the rules of surveillance. This is a paper that we published not very long ago in the Journal of National Cancer Institute, and noticed that in non-high risk patients, again, I think the notion of high risk is important. So in non-high risk patients, we propose to defer the assessment of LVEF in several populations. So we will see how that evolves. And finally, just one slide, just to move beyond the LVEF and the strain. There is a variety of new indices that may or may not be interesting. Certainly, the regional pressure-strain relationship has been touted in particular by the team of Otto Smithset in Norway as an index that's reflective of the metabolism and the oxygen consumption of the myocardium, and that may be interesting. We will see. And then this is something that I feel very excited about, a very high frequency machine that allows us at like 1,000 hertz to look at the stiffness of the myocardium by a process called elastography, and which may help in tissue characterization. So those are the take-home messages of this talk, Echo in cardio-oncology. I hope I have convinced you that there are deep connections between cancer and cardiovascular diseases, that Echo is crucial, and at present it's mainly used to characterize cardiac function. The LVEF 3D, if it's possible, it does have prognostic value, it does have therapeutic implication. The strain is more sensitive than the LVEF, I have no doubt about that. The risk assessment, I do think it has a role there in the patients with cancer treatment. The prognosis is likely higher than LVEF in certain population. The therapeutic implications haven't been proven yet, and trials are needed to show that therapeutic decisions based on strain improve outcome. And finally, I thought it was exciting, but maybe in future, Echo will be able to do some tissue characterization. These are the collaborators and the funders, and I thank you all for listening.
Well, thank you very much, Dr. Scherrer-Crosbie. That was a tremendous tour de force of the current state of the field. We have a few minutes for questions, and why don't I'll go to the chat box first, and then Lou, maybe we can get to you next. The first question from Nazmi Syed, who's one of our most experienced sonographers, is a very practical question from a very practical person, of course. The bane of our existence in the Echo Lab, the technically difficult study when EF and strain are really not that reliable. how do you do the report, but also what do you do in general? What's your approach to those patients?
Yeah, no, I mean, it's a great question. So we have really, the first thing, we have really increased our use of contrast. We have been very, very happy with a contrast product that we hadn't used until recently, and that really, in our hands, gives significantly better images. We do, I would say, 20 to 25% of our patients with contrast, which for us is a lot. We have observed some side effects, especially since the vaccine. There was, we published a letter in the JACE for that, and I know that John Midner is publishing something too in that particular arena. But nevertheless, I mean, we have really increased our use of contrast, and that has helped us a lot for the LVEF. So with contrast, you cannot really do strain. Most of the algorithms don't work. There was a paper from Victor Moravi's team in Chicago that said you could use half of the contrast dose, but I don't know. We just don't do it. So that's for LVEF, yeah. I mean, what we recommend and what all the societies have recommended is that if echo is not good enough, you have to do the EF with an alternate method. I mean, CMR comes to mind, yeah. I think that, it's important enough that, especially in high-risk patients, again, to have, a follow-up and a baseline and a follow-up EF, at least EF, yeah, if you can't get strain. So that would be the recommendation.
Great, thanks very much. And maybe time for one last question, Dr. Coleman.
Yeah, thank you for a really wonderful talk, and it's always nice to have a ground round speaker coming from my hometown also. And my alma mater too. I was placed my heart for Penn. So I'd like to know about your relationship with your oncologists and hematologists. How you share data resources, how you meet with them, and just a little bit your relationship with the cancer doctors.
Yeah, it's a great question. It's so I'm not going to be very scientific there. I mean, it's so dependent on the personalities. So we have we have a series of presentations at their research meetings. We our cardio-oncology unit is very close to some of the oncologists. We would never take a decision. We can put patients on cardioprotective drugs, but we would never even mention interruption to the patients without consulting with the oncologist, and we would do that only for patients with very low EFs and in whom we are really concerned, and this would be a discussion with the oncologist. So I mean, it boils down, unfortunately, at this point, there is no, we have meetings where some of the oncologists attend, every 2 weeks we have a case meeting where, some of the oncologists attend, but then some do not. And, there are a few oncologists who are very resistant to whatever the cardiologists are saying. And it's a question of culture and of changing the minds, but at the same time of acknowledging that you cannot interrupt a treatment like that. This just is very, very counterproductive. I don't know if that has answered your question. I mean, it's not very scientific, but that's where we are at the moment. Yeah.
Thank you.
Yeah, thanks very much. Carlos has a question, but I don't know, do we have time for that? I think if it's okay with you, Marielle, we can add, it's a great question from Carlos. Sure. So sure. It's any chance you envision identifying susceptible patients early by inflammatory markers and then treating them for both their cancer and their cardiovascular disease? So
that's
CANTOS approach, yeah.
So that's a great question. We actually are working on that. But the caveat is that many of those inflammatory markers are non-specific. So, you don't know if it's because of the cancer, if it's, but yes, we actually have, we'll see if it gets funded, but we have, we have proposed something similar, to try to identify patients who are most at risk. But again, I mean, it's not, unfortunately, it's not that easy, depending on the type of cancer, depending on the extent of cancer, you might have really non-specific increases. When I say non-specific, I mean non-specific for the heart, yeah. So.
Great, thanks very much.
Well, that was great. Thank you very much.
Thank you. Thank you so much for inviting me.
Yeah, wonderful presentation, and really I learned a ton, as always whenever I hear you speak. So tremendous presentation, and thanks very much again. And maybe one day we'll get you to visit Calgary on a warmer day.
Yeah, or you come to Philly.
Or I'd love to come to Philadelphia with Dr. Coleman in his hometown.
Absolutely,
So, yeah.
I count on you both.
Yeah,
Okay,
good.
all right, thank you so much.
Thanks very much. Thanks
Bye-bye.
again.